So my name is Swaans. I'm from cardiologist from the Sint Antonius Hospital in the Netherlands. And I sort of partly present this presentation with Nina. We made this presentation 2 years ago when she had the option to be here and discuss this. I will try to give you an update on the imaging part for LAA occlusion. Let's see. So, why is imaging so important? Because there is just an enormous variability in LAA morphology. And of course, they are 3D, complex and relationships. And the measurements immediately have influence on design or the choice of the device you're going to implant. And of course, we want proper alignment with the implantation of the device. And poor image quality or inadequate image quality may lead to prolonged procedures, higher radiation and contrast exposure, suboptimal placement of the device, and even worse, maybe higher risk of perforation or embolization of the device. So, what are the options? TE miniaturization, 3D eyes, fluorofusion, we already saw this in the previous speaker, so CT planning or CT fluorofusion, 3D prototyping, and holography. So, I think you already answered this question, isn't it? So that's easy to go. I think the majority, was it yes always? I think the majority had or should we do it again? Should do it again? Maybe you can vote again for this question, please. So do you routinely use CT prior to LA occlusion? Okay. So on the one hand we have people that always use it, and on the other hand we have people who don't use it at all. So interesting. And the other question is, what is the future of imaging? And this is prior to the procedure. I will get back to you after the procedure to ask you again. Maybe you have changed your mind then. So the options are eyes with some fluoroscopy, fusion imaging, I think it was highly liked in the previous presentation, echo only with only limited or no X-ray, and maybe X-ray only. Please vote. Okay. Let's see if it's going to change after the presentation. So moving on, so let's have a look at smaller TEE probes. And we have different options nowadays because the biggest burden frequently, and that's why the procedure is frequently done under general anesthesia, is the big TEE probe that has to be in the patient, and that's quite inconvenient for the patient. So getting rid of the TE probe, so going to eyes or something like Sergio Berti does, or maybe we can use smaller probes, and I think Nina already showed you the micro TE, but another option is now the mini TE. On the downside we can see the specifications of the different probes, so we can see this micro TE, that's what we most frequently use actually in all our procedures. It's more or less like a gastric tube, so after inserting this probe, the majority of patients doesn't have any complaints at all being awake, so that's what we really like. The little bit older patients, we frequently also switch to the mini TE, who has a little bit more elements, so image quality, and I will show you, is better. But they all got a full suite from 0 to 180, no 3D capabilities at the moment, like in the 3D probe, but you can see the micro TE is more or less the half of the 3D probe at the moment. So what are the images? Let's see if they were on. Yeah, it's a little bit more currently than on my MacBook, but you can see at least that the image quality is quite fair. You can easily detect the LAA, the different other structures in the different degrees we do before device sizing. But you see the images are a little bit more blurred. They're not crisply clear as we know from the 3D TE probe images. But we definitely can do the procedure. So this is the bicave view and the short axis at the base view. We can see the tenting in the mid part or inferior part. And on the short axis we move a little bit to the posterior side for better alignment of the sheet in the LAA. Moving on, here we pass the sheet through the intraoral septum, and then we can do all the different measurements depending on which device you're going to implant. And we can insert the sheet, properly align it, and we can do measurements with afterwards and look at color. The problem with the micro TEE, I must say, on the short range, so in the near field, color is quite good. But if you go a little bit deeper, so if you're looking for doing, let's say, TEVRs with this procedure, I think the color Doppler is really going down. So intra-atrial septal closures like PFOs or ASD is okay, and LAA. But going a little bit more down to the ventricle, color Doppler becomes a problem. But I think still image quality is quite fair and good enough in the majority of cases to do this procedure. Now moving on to show you a little bit of the comparison with the 3D probe. So on the left we can see the micro TE, and on the right we can see the 3D matrix of the probe. And I think still you can quite very nicely see it's a little bit more blurred, but actually all the contours and the good shape of the LA can be very nicely seen also with the micro TE images. Just another one in a different angulation. Again, same shape, a little bit more blurry than the matrix TE. And we did a comparison with the micro TE compared to the matrix TE, and what we saw that there was a very good correlation. If we do the measurements for LAA sizing, correlation was high, but we saw that the micro TE frequently underestimated the LAA size. So that's something you have to keep in mind when you're selecting your device for LAA occlusion. So if it's on the border, frequently you have to oversize a little bit more. Now moving on to the mini probe, 48 elements, and you immediately see image quality is really increasing. Image quality is quite fair, actually. I think like the previous probe, the normal TE probes, and excellently can show you the different structures of the heart. A little bit more better lining, but the big advantage of the mini TE probe is really the color Doppler, which is really good, I think, like a normal TE probe. And in this case, that's what we frequently use for TEVR cases or these kind of things. If you could move a little bit more deeper in the in the heart. Color Doppler is really good, so this is what we use for conscious sedated TEVR patients. Moving to a procedure we did Wednesday, hopefully they run, yeah, the different views before the procedure again, nicely showing and easily to recognize the structures and do the measurements on this. And then after sheet placement, completely in the LAA, we move on to the measurements and placement of the device, and this is post-implantation with color compare, turning the baseline really down to 30 centimeters a second to find these small leaks that can be more hard to detect, and very nicely seen that this is a perfect placement, in this case a Watchman device, with an excellent closure of the LAA. So 3D eyes, and I think Sergio Berti will later on discuss this as well, so I will shortly go into this. It was already seen that eyes can be used in the procedure, so in the majority of cases, 85% eyes was capable of showing the left atrial appendage properly from the right atrium side, and compared to 96% using a TE. So it's a little bit less, but also if you use different angulations or different placements of the catheter, this might go up and better. And it might even be better when we switch to 3D, but this is what the images Nina showed 2 years ago. The volume size is quite small, so I think it's 3D, but it's more like a fixed slab at the moment. So that was a big problem. And now the newer Siemens EchoNav is going to be available this year, and you see, I think image quality improved. The volume size is going to be increased, and I think also the color Doppler, oh, it's not running down below, but, oh, there we go. I think the color Doppler and these kind of things also really improved, so I think this is a better option. This is really 3D instead of a fixed slab. And it also has this dart function in the 3D, so you can place, or you call it two-click crop, in your 3D volume, the structure you want to look like. So on the right bottom, we're looking at the left atrial appendage. So going to fluoro echo fusion, and I think the previous speaker already discussed it a lot, so I go a little bit quicker over it. But the biggest problem is we use echo and fluoro during the procedure in the majority of cases. But of course, fluoro can very nicely show you the catheters and the devices, but has a poor visualization of anatomical or the soft tissue, so that's why it needs radiation and contrast. But if we move on to the echo, Of course, this gives very much a soft tissue, but it's more difficult to get and detect the devices and the catheters. So, and what the interventionalist actually is doing in the cath lab is already combining these images in his head. And why make it so difficult to have him look at two screens? Majority are men, interventional cardiologists. We're not like women. We cannot do multiple things at the same time. So make it easy and just look at one image at the same time. So what it does is this is a co-registration of the head of the TE probe in the fluoroscopy space, knowing immediately where the TE probe is looking in the fluoroscopy space, and we can make an overlay, and we can do this with cropping, rotation, and a lot of tools are added for this. And just to show you, in the first release of the EchoNav, we can only place a dot, so it was no real fusion imaging, it was more a co-registration. So for example, if we wanted to do a transeptal puncture, we can mark the spot where we wanted to aim for and then go there with the needle. But with the release 2, we can really overlay the echo images on the fluoroscopy, and we can see on the right there is a bicave view, and I will show you the next images, and we really can rely on this. I will show you. So what we now more and more do is that, because in AP it's not always the right view to do the transeptal puncture, so we rotate the angulation of the tube till we have a nice bicave view, insert the needle in the SVC and get down till we see the needle dropping in the fossa ovalis, and there do the puncture. And I think you already saw this, but very nicely, good correlation with the images, and immediately now you have an understanding where you're looking at, because that's sometimes quite difficult to understand in complex anatomies. This can be done with 3D, but you already saw this by the previous speaker. It was courtesy to him. And we're going to, but this is the new concept, and maybe you haven't seen this, because this is using the anatomical intelligence of the EchoNav, and we already seen this in the EPIC on the transthoracic images. He's using models to create even more structures in the heart and to get a better overlay. So, and you can decide which structures you're going to overlay. So, of course, you do not want to have too much images to have overlay, but only the relevant structures. So you can decide which are important for your overlay, and you can click on or click off them. And I think especially in difficult anatomies or difficult structural heart interventions, this is really going to help, because you have a better understanding where you're looking at your fluoroscopy screen. And if we move on, and this is from Occlusion, and we can see it already has a valve and a mitral clip as well, so it's they already made some money on this patient, but it can help you to get an idea where the LAA is, as it saves radiation and also contrast, because you can already see the dilation of the LAA. Position your sheet nicely in the LAA without using contrast. This is just to show you, because I showed the micro TE. This is not a real product at the moment, but since we want to get rid of the anesthesia and make the procedure faster, it might be an option to fuse images, fluoroscopy, with the micro TE probe. This is a mock-up that doesn't really exist, but we just made it with Philips together. But also with a micro TE, it might be possible. The difficulty is that the head of the micro TE is of course much smaller, so it's much more difficult for the software to recognize where this probe is looking at. But again, different angulations, and we immediately have an impression where the LAA is located, and we can do measurements and maybe get a better understanding where the catheter is going to, and using less contrast. So moving to CT planning or fluoro CT fusion, we already know that CT is an additional value if we do the workup of patients for an LAO occlusion. It nicely shows the morphology, the difficult morphology sometimes, has of course a very much better spatial resolution than echo, and it can be used to get a 3D cutoff of the LAA ostium. Instead of that measuring with TE the biggest diameter, we can do the parameter or the area measurement, and this is probably going to be better for sizing of the LAA device than using only the maximum diameter. I think majority of people already knows Trimentio or uses Osirix to do this, but the Trimentio software is quite easy. It automatically segments the heart, And just after segmentation, we get a volume rendered and a multiplanar reconstruction. And for this, we just mark the LAA ostium by 2 markers. And then we get a plane where we can do measurements on, and we can use this plane to get the best angulation. We can simulate that and to see what is the best optimal angulation for doing this procedure. Is this really better? Because quite a lot of people are using this, and this is a publication from 2016 from Didi Wang, and they examined for the learning curve the impact of 3D guided procedural planning on the learning curve, and they compared it with the original Protect AF data from the beginning. And what they saw and what they did is that they used the CT to completely recommend device size, catheter selection, and the C angle for the implantation. 53 patients had a successful implantation with the Marchman, and they saw that the accuracy of the CT measurements that were done was 100% correct. And I'm a little bit of doubt of this, because they say 62 and 53 of the patients when using the 2D TE measurement or the 3D TE measurements would require a larger device than calculated, so there was underestimation of the OS. But I think 3D already has shown to have a very nice correlation with CT, so a little bit doubt that these numbers are really that high. But what they saw is that they have less devices implanted and a higher success rate when they compared it to the early Protect AF trial. Now Philips also has a new tool, the Heart Navigator, where we can do the segmentation of the heart. It actually automatically segments the heart. And if we go to the LAA mode, we immediately can go to the ostium of the LAA. I'm not going to show you completely, but if it's not correct, we can always adjust this. We can inject some dye to really delineate the LAA ostium. I go to skip because this takes quite some time. And again, we can see this model-based image of the complete heart. And of course, for the LAA occlusion, frequently we only need the left atrium, the left atrial appendage, and maybe the right atrial for the transeptal puncture. But we can look at it from the different angulations, and if we move on, we can just go on and do different measurements on the LAA ostium, device size and depth, and use this for the overlay. Unfortunately, I cannot show you the overlay images yet, but it can be overlaid on the fluoroscopy images. And again, also this has a software tool to calculate the optimal angles for implantation. And the nice thing is, if you have Siemens software on or Siemens cath lab material, you can immediately send these projections to the cath lab machine itself, so it knows it has a sort of standardized views then. Moving to 3D prototyping, and we already saw in 2008, we can, in structural heart, difficult, complex structural heart, we can make this 3D print to better understand what is really going on in these patients, and it very nicely, of course, shows the anatomical borders and shape of the LAA. And this gives a sort of exact replica of the anatomy of the patient created on variety of materials. But of course the limitation is it's only approximate replication of the underlying tissue, because you don't exactly know what the underlying tissue might do. It costs around $200 to $300, and process time, a little bit depends on which article you're going to read. It can take up to 6 to 16 hours or something like that, but it might help to use different devices to see how which size is the best and which optimal angle to implant. And what they did in this study, I think is nice, it's from 2015. What they did 3D printing of the LAA, and in this they used different Watchman devices to see which one might fit best. And on the left side in image A, we can see a 21 device. There seems to be actually no compression at all. In the 24, there seems to be a little bit more, and you can see the 27 on the right side is a little bit highly compressed. And what they did afterwards, and I think that's going to change in the future, but what they did is put this model back in the CT again and put it in software where they can calculate the stress on the left atrial wall. We all know this is a thin layered structure, and where they can see that there was almost none, let's see, there was almost none compression of the left atrial wall. In the 21 device, there is some compression, but not above the threshold in the 24. And in the 27, we can see some spots where there was a highly threshold or a lot of pressure on the left atrial LAA wall, and also on the posterior side. And of course, when the stress is much higher on the left atrial wall, there might be a higher chance of getting embolization. Based on this, they implanted the 24 device, which was excellently placed. So going to the final step, and I think, and I can even show you more, but I had to select. But this might also be interesting. Hopefully it will run. And this is from Grey's Anatomy. You might have seen the show, but it was a few years ago. And at that time, they always like to show fancy stuff. Of course, it's a drama. So at that time, there was no real fusion, but already they predicted that we might be able to look at holograms during the procedure. But actually, this is becoming more and more realistic nowadays, where we can use the 3D capabilities of our Echo machine or CT, it doesn't matter, but Echo is of course live, where we get an in-air holographic display where we can interact on. And the idea is that the interventional cardiologist at the end will get a sort of glasses before his eyes where we can switch on and switch off the holography during the procedure to have an idea what is going on in the patient. And this is just a prototype at the moment from a CT set, I must say, but they're getting a nice idea of the whole anatomy of the heart going around and looking in. And the nice thing is, and I think they're going to show it, that you're going to click, you can rotate it, but also can click on structures to get them away, again like we saw. So only the structures that are relevant we can put in the image, and if we use a specific tool, we can crop into the left atrium in this case. Let's see what we're going to do. First we're going to rotate again. We can nicely see also the left atrial appendage, and now they can crop into it. And because it's from a 3D TEE probe, it's live, so you can do this all the way live during procedures. And now you can also do some measurements here on the left atrial. This is upper pulmonary vein. We can do measurements for ablation procedures. But also, and this is from a TEVA procedure because it hasn't been used for LAA occlusion procedures, but like here we can nicely see the deployment of a valve into the aorta, and it will show you, you can also look at this during the implantation from different angulations and look it over and over again to see how it fits into your aorta. But I can imagine you're going to do this with LAA occlusion as well, where you're going to have a look at different angles if your LAA closure device is well positioned. Let's see, we're going to rotate it from the upper side. It's not that. Here we go. It's also fun to play with, how I can imagine. But here we go, completely looking at it from different angulation, getting an idea of the position of the device itself. So, imaging strategies may potentially lead to more accurate LAA evaluation, more convenient procedures for the patients with the smaller probes or using eyes, faster procedures probably due to better planning of the procedures, safer even, less radiation and contrast exposure, and more precise results. And of course, this is what we want for the long-term results, and less complications. Oh. It wasn't me. Okay, so again, after the presentation, I'm curious if the audience has changed its mind. So what do you think the future of LAA imaging would be? Please vote. Okay. Holography got a lot of people. Good. So I think the biggest conclusion is that we sort of getting rid of a lot of the radiation exposure and some new of the integrated tools and holography for implantation. So Thank you very much.